I'm now back to the current approach. I don't need to emphasize that chronic GvHD is a continuing challenge. In this challenging situation, we still stick to steroids a lot, not only in first-line treatment, but have to acknowledge that our first-line approach is failing in a significant proportion of patients, and steroids are pretty toxic. It's likely one of the most toxic drugs we can use in our practice. Now, thanks to a fruitful collaboration between pharma and academia, we have now 4 agents approved in the field, and here's the timeline for that, and raising a more challenging question, or in fact a luxury question, which agent to use. Now, I'm sharing that slide summarizing the results of those 4 agents and where approval studies, and showing that each agent works in a subset of patients, but not in all. That's one. And in some of those responses, the response is not durable. We heard about it this morning. And most importantly, ruxolitinib is the only drug which was compared to other agents in a prospective trial. ECP was not on the list because it's a medical device following some different regulations, but it's part of clinical routine with a comparable response rate. It was the second best in the REACH-3 trial, already illustrating that the challenging chronic GvHD is that a complete remission is probably not the goal, because some of those changes are in a way non-reversible, that whatever we're doing, we will never improve that. This is mostly true for sicker symptoms and for advanced lung disease. We talked about that. So the question how to approach steroid refractory or steroid dependent disease is a challenging question, because we have no consensus on optimal sequence, except the approval status guides our sequence to some extent. The treatment efficacy varies across organs. That doesn't mean necessarily that one organ is responding less than another. It's just the time frame which may be different. And all those agents I already shared have very different mode of actions. But when we go to clinic, the mode of action and the biology is not on the list of the decision, the reasons guiding your treatment. So it's more guided by availability, so approval status, published evidence, the toxicity profile, the comorbidity, and clinical trials. So when to start second-line treatment? There's a fair consensus across the globe that if the patient is progressing on a full dose of steroids for 1 to 2 weeks, it's very unlikely to respond later on, or you have stable disease on a significant steroid dose for 2 months, or you can't taper the steroids below 0.5 milligram, or you don't tolerate the steroids at all. There are some red flags which should trigger the treatment switch, which is in skin, either an enlarged area involved through treatment, or the change of the involvement. If you go from inflammation to superficial sclerosis or deep sclerosis, that indicates your failure. In eyes and oral GvHD, it's always good to first consider optimizing your topical treatment, but if this fails, it should trigger a second line or a subsequent line. In fact, the PRAM scale helps in lung function testing. If you wait crossing those red flags, you just risk that the patient will end up in a situation with significant impairment on the long run. For third-line treatment, the trigger to switch treatments or after failure of second line is exactly the same, except that those patients are already exposed to steroids quite a while, and the steroid threshold should be lower in that situation. Still, there are some things to be considered. First of all, avoid changing more than one drug at once, except in case of complete failure or toxicity, because it would be hard to dissect afterwards what the response was due to. Then the next thing is to differentiate between GvHDs and toxicity, including infections and in the longer run, secondary malignancies. The next question you should ask, am I treating chronic GvHD? Have I ever seen a diagnostic syndrome, or is there something else on top? And end up do a histopathology. And we all learned about the triggers of GvHDs, and the question is, can I target one of those triggers, like mechanical irritation and oral mucosa? So how do I approach, and I think I would exchange all by V. We first have to sort out whether our treatment works, and then to define time frame, we have to kind of keep in mind those triggers to switch the treatment, which I just have mentioned, keeping an eye on the cofactors. And then I already shared our decision tree, how the next treatment line would be chosen. One thing to be mentioned is sometimes we end up with just putting one after another on top of a patient medication plan, and that's likely not a good idea. There's no indicator that more than 3 agents at once are effective, and even 3 agents needs to be justified. And most importantly, please be aware of synergistic toxicities. Where, for instance, ruxolitinib combining with MMF would add infectious toxicity and cytopenia. That's likely not a clever combination. During steroid tapering, toxicity and efficacy drives the decision. When steroids are usually the one agent which is taken off first, having said that, we all acknowledge that there is a certain subset of patients who require a small dose of steroids, regardless what you combine with. Ruxolitinib is already quite a while in clinical practice, and I just share here 2 single-center analyses illustrating one of those challenging and misunderstanding in the field. And with lung GvHD response rates, for instance, I frequently hear that comment, Ruxolitinib doesn't work in lung, which, based on published evidence, is not true. It's just that the response rate might be a little bit lower, since it's never been really compared, we even can't say that. But there is one specific thing with ruxolitinib compared to other agents now approved, is that infectious comorbidity is something which we more frequently see with ruxolitinib as with other agents, and especially in those patients with infectious phenotype BOS, that can be challenging. So what are the unmet needs in the field of chronic graft-versus-host disease? If you ask different countries, even inside the EU, agents are sometimes approved but not refunded, and in other regions of the world not approved at all. Treatment is often initiated too late, although we have been challenged by the fact that all those first-line treatment combination didn't work for various reasons, which we will discuss tomorrow. The optimal duration of treatment is an unknown field. Stephanie just covered that this morning. And one thing we are challenged with is the characterization of the immunodeficiency of our patients is more driven by the events than by lab values. So we just kind of observe those infections, but we have a hard time knowing why. And it's not only low immunoglobulins. The sequencing and combination is an unknown field. Organ-specific approaches. Currently, we treat all patients the same because of lack of data calling for an organ-specific approach, except the topical approaches. And the trial and error system is something which we need to work on. And another field of a lot of unknowns is how to treat atypical manifestations. So what are the key takeaways? Advanced fibrotic GvHD, and that can be a very early event in salivary glands and the lacrimal glands. is often non-reversible, underscoring the importance of early detection and intervention. Prolonged steroids are likely not good for anyone, and the investigation and approval of steroid-sparing drugs in the recent years has enabled us to do a little bit better. Actually, if you compare curves from the past, the survival curves in the past on the same severity of chronic GvHD disease, we acknowledge a significant progress in our clinical practice, but we're still a way space for improvement. And those are the challenging situation I've listed here: how to combine, how to sequence, how to deal with this multi-refractory, multi-organ disease.